Okay, do you see me?
Yes, ma'am.
So, well, as usually, so before speaking about disease, let's remember normal physiology of thyroid gland. Look at this picture, please. Look at the center of the picture. You see here, it's of course a schematic structure of the thyroid gland, of the cells of thyroid gland. And so you see here colloid in the middle of this circle, colloid cells. So colloid by itself, which is a thyroglobulin, follicular cells, and between follicular cells, vessels, and parafollicular cells. So thyroid gland regulated by hypothalamus. Hypothalamus produce thyroid releasing hormone. Thyroid releasing hormone secretes, stimulate pituitary gland. Look at the left part of the picture. It stimulates pituitary gland to produce TSH, thyroid stimulating hormone. And TSH effect on T4 and T3 means on its secretion. Thyroid gland produces 90% of the hormone which is produced in thyroid gland is T4, 10% is T3. So how it happens? Also, thyroid gland also produces calcitonin, the hormone which controls calcium metabolism together with PTH. This topic we also will discuss in our classes. Well, look inside of the thyroid follicle. How the process of thyroid hormones developed, how it's present in our thyroid gland. Look here. What you may see, if you look at the left part of the, from the right part of the picture, purple arrow means iodine. From blood, our thyroid gland absorbed iodine. We need iodine for thyroid hormone secretion. So thyroid gland absorbed this product from our blood. What are the resources of iodine? Food, water, seafood, products which with iodine like salt. And but actually people who live near the sea, near the open oceans, near the oceans, they have iodine. They may take iodine from any part of their product, in all plants, in meat, in milk, in vegetables, everywhere present enough iodine. People who live far away from the oceans, like here in Kyrgyzstan, we have a problem with iodine in our products. We do not have enough iodine. That's why we need to do iodination of salt for prophylactic of iodine goiter, iodine deficiency goiter. Well, thyroid gland uses iodine. What happened next? Look, please, at the nucleus of the thyroid cell. Look, on the surface of the nucleus, there are many, many black spots. These black spots are receptors to TSH. It's very important that to remember that all hormones have their receptors. And for understanding of Graves' disease, our topic today will be Graves' disease. You need to remember that on the surface of the thyroid nucleus, on the follicular cells, there are TSH receptors. Receptors to thyroid stimulating hormone. It produced in pituitary. When TSH stimulates follicular cell in thyroid gland, when it stimulates its receptor, follicular cells, they produce thyroglobulin. Thyroglobulin, it's a protein, the basis of thyroid hormone. Then thyroglobulin, look, according to the exocytosis, it is transported to the colloid in the middle of the follicular cells, into the middle of the follicles, it transported to colloid. Then, with the help of enzyme, which is called iodinase, iodine also transported to colloid together with iodinase, iodine connect with thyroglobulin, and with the help of enzyme thyroid peroxidase, the part of the molecule with the hormone. So thyroglobulin consists of tyrosine, part of this molecule due to endocytosis once again absorbed back to follicular cell by proteolysis, destroy the chains between protein and hormone molecule and secreted back to blood. If 3 molecules of iodine connected, we call this hormone T3. If 4 molecules of iodine, T4. 90% of the hormone which produced in thyroid gland is T4. Hope you will understand this. Because we start discussing the syndrome which is called thyrotoxicosis syndrome. It is a clinical state which is associated with excess thyroid hormone activity, usually due to the high level of thyroid hormones in blood. So thyrotoxicosis is a clinical syndrome. But don't please tell me that Graves' disease is a thyrotoxicosis. Yes, it is so, but there are many reasons of thyrotoxicosis. What are they? In etiology, you may see these microphones. So in etiology, you may see that the basic reason of Graves' disease is, of thyrotoxicosis is a Graves' disease. I will speak about Graves' disease today, all lecture. Then, second reason is toxic multinodular goiter. It's another condition, it's another disease, but this type of goiter, so this multinodular goiter also may provoke formation of thyrotoxicosis, elevation of thyroid hormones. Toxic adenoma, it's a one nodule, which may produce too much hormones. Various types of thyroiditis. Thyroiditis, it is an inflammation of thyroid gland, subacute, post-viral thyroiditis, for example. Post-COVID thyroiditis becomes very spreaded among patients. These 2 years, we see that COVID infection is very sensitive to thyroid gland, destroys cells of thyroid gland, and for a few months may provoke formation of thyrotoxicosis syndrome. But then usually we see full recovery. Drug-induced thyroiditis, using of some medication also may destroy thyroid cells, and due to this, people also may have thyrotoxicosis. And last cause is exogenous thyrotoxicosis, when we treat people with the thyroid hormones, for example, hypothyroidism treatment, we can overdose, or sometimes we need overdosing of this drug if it is thyroid cancer, and we may see artificial thyrotoxicosis using of medications with thyroid hormones. All these are thyrotoxicosis. As I said, this is the syndrome which develop in the patient body, in person body, due to the over-secretion of thyroid hormones in blood. This is the difference, or with another meaning, which is called hyperthyroidism. Hyperthyroidism means the thyroid gland produces too much hormones. Thyrotoxicosis, it's a syndrome which develops due to the overfunction of thyroid gland or over activity of thyroid hormones due to the exogenous causes. Don't mix these 2 reasons. But because Graves' disease provoke 90 to 80% of all cases of thyrotoxicosis, this will be our topic today. It's the most common form of hyperthyroidism. This is another autoimmune disease. In endocrine subject, you see a lot of autoimmune disorders. Yesterday, we discussed one of these. It's a type 1 diabetes. Now, it is a Graves' disease. Graves' disease, it's also autoimmune disease, but it is very specific type of autoimmune disease. So very specific type of a disease which provoke overfunction of organ. If you look at the other types of autoimmune disorders, you will see that autoimmune disorders provoke destruction of the organs, like type 1 diabetes, like SLE, like rheumatoid arthritis, etc. but in Graves' disease, thyroid gland by production of antibodies, which are called TSH receptor antibodies. This is the antibodies to the receptors of TSH on the surface of thyroid gland. So thyroid gland cannot understand what attacks it, TSH by itself or antibody to TSH receptor, which has a very close structure as look like it imitate TSH function. Thyroid gland start production of thyroid hormones in high concentration. You'll see hypertrophy, hyperplasia of thyroid follicles, usually in young age, more common among women than in men, but in men it's also present. So look at that picture once again. We call it autoimmune phenomenon. The more antibodies present in blood, the more severe is disease. TSH receptor antibodies, we also may call them TSAB, thyroid stimulating antibodies. They attack TSH receptor and stimulate thyroid gland to produce more hormones. Classically, symptoms of Graves' disease include hyperthyroidism, of course. 90% of cases, people with Graves' disease, they have specific symptoms of this condition. They have elevation of thyroid hormones and classical symptoms of the disease. So 50% of people have goiter, enlargement of thyroid gland, but not all of them. Only 0.5% of people. Goiter have not everyone. Then ophthalmopathy, eyes changes in the patients. These changes in eyes present only in 20 to 25% of cases. And then next slide, I will show you what photos of the patients with the Graves' disease and ophthalmopathy and to explain why it happened. So look at the signs, symptoms of thyrotoxicosis. Thyroid hormones, why do we need them? What is the function of thyroid gland? Thyroid hormones, T3 and T4, they control metabolism. They control metabolism. They control general rate. They increase temperature. They control movements of GIT. They control heartbeat and nerve system impulses, etc. When the level of the thyroid hormones increase, you'll see that these all metabolic changes, anxiety, mood swings, hyperactivity, irritability, dysphoria, occasional mental impairment, exophthalmos, high sensitivity to light, means in eyes, fatigue, maybe weakness, muscle cramps. People become very nervous. They have shortness of breathing. They have tremor. They have specific changing in behavior. They may quickly change their behavior. They may start crying without reason. They may start laughing without reason. So absolutely emotional lability. The temperature of the body increase 37 to 38 degrees. They may have diarrhea because thyroid hormones stimulates quick movements of GIT. They have heat intolerance, and because of high temperature and frequent sweating, they have increased appetite, insomnia, and weight loss, of course. Symptoms are classical, and usually we so we can say that people with Graves' disease, we can put their diagnosis when we look at them, just on the first glance, when they come into our room. Really, the symptoms are so specific. So they have shaking of hands, they have mood swings, they have bulging of eyes, atypical behavior, sometimes very quickly speech, quickly movements. Sometimes there is no doubt what the condition is it. Once again, the clinical symptoms, clinical features according to the system, cardiovascular system, first of all, palpitation and tachycardia. Unfortunately, if we do not treat Graves' disease, patients will have complication of this condition. It is called atrial fibrillation and heart failure. because thyroid hormones are very toxic to the heart muscle and may provoke fibrillation. In this nerve system, irritability, insomnia, restlessness, proximal muscle weakness, sometimes tremor, usually tremors. In GIT, increased appetite, hyperdefecation, thyroid gland would be enlarged, would be not, goiter present in only 50% of cases. What is Graves' ophthalmopathy? As I said, 20-25% of patients may have these eye changes because it was shown that in tissues which surrounded eyes, also there are TSH receptors. And you may see autoimmune inflammation of retroocular and tissues which surrounded eye. So you see here T-cell inflammation. Patients will have pain, redness, edema. In severe cases, ulceration of the eyes, compression of the optic nerve. It was shown that people who smoke, they have a higher risk of this complication. Well, in this photo, you may see the man with the bulging eyes before and after treatment. So these changes very visible, especially when we start treatment very quickly, you will see normalization of situation. It's another picture of the woman with the redness, with the ophthalmopathy, specific changes of engraved disease. And another one. This girl, she also have myopathy, so ophthalmopathy, and with the inflammation of muscles may provoke double vision because of you see that pupils are not symmetrical, non-symmetrical inflammation of eye tissues, of muscles, may stimulate this side effect. And also this woman, she also have ophthalmopathy. So you see swelling of surrounding tissues, which is not nice, which is not good. And of course, we need immediate treatment because there is a high chance of vision loss in that people. So what we'll do in diagnosis? According to symptoms, it's not difficult to put diagnosis. And these people, they usually come to the doctors very quickly. They do not wait a long time because now it's possible to search all the symptoms in internet. And absolutely, it's not a problem to understand what disease they have, so that they need to go to endocrinologist or general practitioner. Our problem is what we will do for diagnosis. First of all, we will examine neck for goiter, presence of goiter or absence of goiter. Then, of course, we will do blood tests, TSH, T3 and T3, T4, ultrasound examination, and radioactive iodine uptake. These are the specific tests which we need for examination of patient with Graves' disease. But please make a note, plus to this, of course, you will do ACG, you will do simple urinalysis, CBC, liver function test, creatinine level. I do not mention it here because I hope that you understand that there are general laboratory tests which we can prescribe. And here these are the specific tests for thyroid gland. So, as I said, just at a glance, you may answer the question, oh, it's a Graves' disease. Just looking at the person in the street, sometimes when I walk down the streets, I look at the people, and sometimes just I notice patients with the Graves' disease and goiters. Nowadays, big goiters are not a common symptom. It is a rare situation. I'm sorry, I need to answer the question. Oh, sorry, mobile. Назир Тарбан, у меня лекция. Потому что у меня лекция сейчас. Я сейчас прочитаю. Но студенты, вон 40 человек сидят. Excuse me. So, if you look here, on this picture, patient has a big goiter. And no, classically, it may present, but not always. As I said, according to the observations, according to many new surveys, patients may not have big goiter. Goiter, it's just enlargement of thyroid gland. Let's don't call goiter as a disease. Goiter, it's a symptom. With big letters, write it. Goiter, it is a symptom. Goiter means enlargement of thyroid gland. There are various types of goiter. In thyrotoxic goiter, in hypothyroidism goiter, nodule goiter, iodine goiter, a lot of various types of goiter, but it is just a symptom. It's enlargement of thyroid gland. In patients with Graves' disease, enlargement of thyroid gland may present only in 50% of cases. Then next, T4, T3, and TSH examination. You see here normal rates. Thyroid stimulating hormone, normal level from 0.4 to 4. 3 to 4 level also here. What will happen in a Graves' disease? Laboratory evaluation. Always remember that in people with thyrotoxicosis, symptoms of in blood, hormone changes in blood will be absolutely same everywhere. T4 will be high, T3 will be high, TSH will be suppressed due to the negative feedback effect. Make a screenshot of this, and again, remember that it is a negative feedback effect, that when peripheral hormones increased, pituitary gland suppress its function. Negative feedback effect. But the next question, which I always ask my students, how you will understand that your patient has Graves' disease? Graves' disease. Students usually answer, because they have elevation of T4. Please remember, elevation of T4 doesn't mean that it is a Graves' disease. For example, subacute thyroiditis also may present with elevation of T4. Nodule in thyroid gland also may present with elevation of T4. Thyrotoxicosis, the reasons are different, but you need to understand, you need to prove. When you see a person with thyrotoxicosis, you need to prove that it is Graves' disease. You need how to do that? You need to know its pathogenesis. Pathogenesis is an autoimmune disease. So, autoimmune disease means you may directly measure TSH receptor antibodies. TSH receptor antibodies, they may help you to identify Graves' disease. They may help you to understand that it is not nodule, it's not thyroiditis. So direct measurement of these antibodies, TSH receptor antibody test. The positive test, 98% of cases, it's a Graves' disease. High sensitivity. Presence of these antibodies shows that it is Graves' disease. You can confirm that. The next, imaging, diagnostic imaging. What we can do here? You may do radioiodine uptake, technetium 99 uptake. These two examinations we called scintigraphia. So we use radioactive drugs within low dosage. These drugs accumulated in thyroid gland and after scanning may show how many iodine thyroid gland uses for its function. Next type of scanning is very easy and very cheap. It is ultrasound of thyroid gland. It may identify nodules and show, first of all, the sizes of thyroid gland. Look down, please. For women, it's a normal volume, normal sizes, not size, volume of thyroid gland. For women, less than 18, for men, less than 25 milliliters. Centimeters are not interesting to us. We need volume of thyroid gland, so ultrasound doctor will show you that information. So thyroid scan, as I said, scintigraphy. It is a very good type of examination. How it look like as in this picture. You see the thyroid gland. It's a brightly shine, and so normal level. This is the normal thyroid gland. It could be colored. It could be black and white. Here you see that the right picture, which is a grave disease. Size of thyroid gland increase. It's also scintigraphy. In the down pictures, scintigraphy give us opportunity to understand maybe it's a nodule which produce too much hormones. It's a toxic adenoma or toxic MNG. It's multinodular goiter. How it look like? Not that's why thyrotoxicosis is a syndrome with various reasons, but grave disease is the most common cause of thyrotoxicosis. Is autoimmune condition. It's another type of thyroid scan, also another picture. The same. So just examples for you to understand how it may look like. It depends on equipment. Some equipment will give you a colored picture. Some equipment will give you a black and white picture in thyroid scanning. So just make a screenshot of these tables. It's a differentiate diagnosis of various types of thyrotoxicosis. So, what we will do for treatment of Graves' disease? 1, 2, and 3. First, anti-thyroid medications. Metimazole, propylthiouracil, 2 drugs. First, 2 drugs. Second, radioactive treatment. Radioiodine treatment. And third, surgery. 3 ways of treatment. We have 3 ways of treatment of Graves' disease. How we will start, please? Immediate medical treatment. Immediate means you will start from this. Don't doubt, we always start from drugs. So thienamides. Thienamides, they inhibit previous 2 drugs, only easy to remember, only 2 drugs, anti-thyroid medications or thienamides. This is the same, metimazole or propylthiouracil. Thienamides, they inhibit central production of T4 and T3, and they also have immunosuppressive effect. Metimazole once a day, PTU also once or 2 times a day, more preferable in pregnancy. May present some side effects like hives, itching, granulocytosis. We should control them. And second type of drug, beta blockers. Remember that we were afraid of thyrotoxicosis because of cardiovascular effects. We need to decrease heart rate with the help of beta blockers. This is immediate treatment. But then you need to choose what you will do next. And you can continuously give drugs. You may recommend radioactive iodine ablation, or you may recommend surgery. So, continued medical management. Low dose of drugs, 12 to 18 months. Please pay attention. You ask that on practice, and I can easily understand. Did you read the lecture or not? Because students do not remember time of treatment, duration of treatment, 12 to 18 months. Or with the red color, radioiodine ablation. Radioiodine ablation, it is a destruction of thyroid gland by radioactive iodine. Or surgery, total thyroidectomy, total removing of thyroid gland, full removing of the gland. Indicators, big volume of thyroid gland, compression of thyroid gland by thyroid gland surrounded organs. When you need to quickly remove it, some complications like heart failure, atrial fibrillation, you don't have time, you cannot wait, you need to remove it immediately. How we will treat ophthalmopathy, these eye changes? If symptoms are not severe, we can give patients eye shades, means glasses, and moisturizing of eyes with using of drops, artificial tears. In severe symptoms, if there is injection and pain, better to give oral steroids. They will be successful here. And if it is severe symptoms like ulceration, loss of vision, we will give IV steroids and sometimes decompression surgery. The complications of grave disease include, if we do not treat it in the correct way, it should be treated fully. It's not a chronic condition. It includes atrial fibrillation, thyroid storm, toxic hepatitis, heart failure, and osteoporosis. So that's enough about grave disease. If you have questions, you're welcome. Questions, now lectures will be short, but it's not enough today. Of course, I also will read hypothyroidism. So do you have questions about thyrotoxicosis, about grave disease? Hey, students?
No, ma'am.
No, ma'am. Okay, so then what I want to do, please give me a little rest for my larynx. Could I start the second lecture at 3:30? Okay, 3:30. And I will finish earlier. Okay. Not at 4, at 3:30. Give me 40 minutes rest. I will start hypothyroidism in 3:30 and we will finish for today. It's okay?
Okay, ma'am. Okay.
Okay, thank you. 3:30, please connect.